welcome back. Today we'll be talking about cardiac imaging. Specifically, we'll be talking about 2D echocardiography to assess LV diastolic dysfunction. How do we assess systolic function of the left ventricle? Obviously, we'll use the same framework and we'll start with assessment of measures of the dimensions of the ventricles. So this would be systolic versus diastolic, and for this we'll be using M mode and B mode ultrasound based techniques. Assessment of dimensions does help in the assessment in the increasing the pretest probability of having diastolic dysfunction, but it doesn't directly give you an idea about the diastolic dysfunction. In this comparison, I've compared dilated cardiomyopathy to restrictive cardiomyopathy and hypertrophic cardiomyopathy, and what you can see is that restrictive cardiomyopathy, which is the most likely to have diastolic dysfunction, and hypertrophic cardiomyopathy, in which you get more and more diastolic dysfunction with progression of disease. Both of these conditions have very characteristic changes in the morphology of the ventricles. So what you see is that in restrictive cardiomyopathy, the thickness of the ventricular wall or the septum may be increased in some pathologies, whereas in hypertrophic cardiomyopathy it is almost always significantly increased, and it is almost the definition of hypertrophic cardiomyopathy. On the other hand, because in a thickening of the wall of the ventricles, they may have a reduction in the LV end diastolic volume in either condition, and this is more so with hypertrophic cardiomyopathy than restrictive cardiomyopathy. Now, the LV ejection fraction is 40 to 50% in most cases of restrictive cardiomyopathy, and typically during the earlier and slightly advanced stages of hypertrophic cardiomyopathy, it is maintained at more than 60%. Now, because the left ventricular filling is abnormal, there is back pressure in the left atrium, and that causes an increase in the diameters of the left atrium over a period of time. This is more prominent in restrictive cardiomyopathy and usually is increased in hypertrophic cardiomyopathy, but again it progresses as the disease progresses, the size of the ventricles increases. So based on this, you can get a fair idea between in differentiating restrictive cardiomyopathy from hypertrophic cardiomyopathy. However, there is a clear sense of things being a little not as clear as you would require to differentiate between them. So what do we do now? So we really can't prove anything here. Correlation is definitely not causation. So what do we know? So what we can do is we can go through with the next thing in our list, that is we measure the velocities, and since we are assessing ventricular filling, we'll be assessing diastolic velocities. Now when we are assessing diastolic velocities, what velocities would we measure? So during diastole, obviously we'd be using Doppler, and in that Doppler we'll be assessing how fast the blood is moving from the left atrium into the left ventricle. So this is the left atrium and this is the left ventricle, and as we've discussed, blood during diastole is moving across the mitral valves, left ventricle. Now this is the flow that we're going to assess, and as we've discussed, it happens in three phases. There is early rapid filling, there is diastasis, and then that is followed by the atrial contraction or atrial kick. Okay, so atrial kick. Okay, so these are the three phases, and let's see what happens in each of these phases, and then we can go ahead with our analysis of the situation. Okay, so what are we going to use to measure the flow? We'll obviously use pulse wave Doppler and or continuous wave Doppler. So either of the techniques are used obviously through a probe that is kept on the chest wall. So usually we use the apical four chamber view to do the same, and in a normal person this is the curve that we get. Okay, so I've actually labeled the diagrams to represent the different parts of the ventricular filling as they occur and how they correspond to the velocity of blood between the left atrium and the left ventricle. So as you can see, in a normal person during the early rapid filling of the ventricle, there is a rapid movement or high velocity of the leaflets towards the probe. So because of that, you get a positive deflection in the curve, and this is your positive deflection, and it corresponds to the early rapid phase. So this is known as the E wave. Okay, During diastasis, as the ventricle and the left atrium have almost equal pressure, the leaflets stop moving as much, and because they're not moving as much, now what you find is that the velocity with which the leaflets are moving is essentially zero. So the curve returns back to the 0 point. And finally, when the atrium contracts, again the leaflets are moved towards the ventricle, and this produces again a positive velocity in the curve. So that is then called the A wave. So this is your normal diastolic curve. And what happens when there is diastolic dysfunction? So with this pressure volume relationship, we have already discussed in great detail. Now in this pressure volume relationship, what you see is that there is a slow reduction in the left ventricular pressure during diastole. So this pressure is not following as sharply as it did in the previous case, but it is reaching the baseline pressure, and there is a normal atrial kick. So because the pressure in the left ventricle during diastole doesn't fall as well, okay, and remember the reduction in pressure within the left ventricle during early diastole is due to ventricular relaxation. So if it is not falling, that means there is an abnormality of ventricular relaxation. So because of that, the velocity with which the mitral leaflet moves towards the probe has decreased. So as a result, the amplitude of our E wave has decreased. Okay, now there is some blood pending within the left atrium because of the decreased flow during the early parts of diastole, and now the atrium contracts. Now because the atrium contracts, the A wave may be normal to slightly increased in size. So what we find is a reversal of the normal relationship between the E wave and the A wave. Now this is what we call grade 1 diastolic dysfunction. Okay, now coming to the next grade, that is grade 2 diastolic dysfunction. In a normal ventricle, it is the ventricular dilatation that is abnormal. So when that goes away, what you get is a reduction in the E wave. But as this pathology worsens and the hemodynamics become more and more abnormal, there is more and more blood now remaining in the left atrium with each cardiac cycle, and because of that, the pressure within the left atrium actually increases. And when the mitral valve opens, even though the left ventricle is not relaxing normally, the pressure in the left atrium is actually significantly higher than expected. Okay, so that does create a significant gradient between the left atrium and the left ventricle, and the gradient here is a result of what? It is a result of a positive pressure between the left atrium, whereas in a normal person the gradient is a result of a negative pressure within the left ventricle. Okay, a pulling pressure, a suction pressure from the ventricle, whereas in this case it is a positive or a pushing pressure from the left atrium into the left ventricle. Okay, either way, what happens is the leaflets move towards the apex, towards the apex of the left ventricle, and that movement of the apex towards the left ventricle results in a positive deflection in our wave. So we get a normal looking E wave. So this is a normal looking E wave. Now what you will notice is after that there is a atrial contraction. Now in this situation, what has happened is basically the E wave is now again greater than the A wave, resembling a normal curve. So this is what we call pseudo normalization. So pseudo normalization will become relevant clinically, and as I'll discuss subsequently. So this is the actual curve that you get. So we've used a pulse wave Doppler here, and we've plotted it against time. So this is the time axis, and this is the velocity of the components that we're measuring. We are measuring the curve. So as you can see here, this is the E wave and this is the A wave, and E is greater than E, the normal configuration. Then in the next case, what we find is that again at the same location there is a smaller initial wave and a larger secondary wave. Okay, so this would be the E wave and this is the A wave. So now the E wave is smaller than the A wave, and if you were to take a ratio of the two, the E by A ratio would be less than 1. Okay, now what we find in the third situation is there is pseudo normalization. Okay, so now both waves are actually slightly tall, but the E wave has become again taller than the A wave. Okay, now the E wave is taller than the A wave. So these are the changes that we find, and this is what we call pseudo normalization. Okay, so how is this a clinically relevant problem? So see, we have two patients here. We have a healthy athlete who's immediately post exercise, and we have your not as healthy uncle who enjoys eating samosas a little bit too much. then his diabetes should allow him technically. So both of them undergo a 2D echo, and we find that on pulse wave Doppler, the LV athlete's velocity versus time curves look like this, that is E is more than A, and your uncle's Doppler also looks like this, that is E is more than A. So that creates a problem. Okay, in the first case, the E wave is tall because the left ventricle is relaxing vigorously. Okay, that is creating a very great negative pressure within the left ventricle. That is pulling the leaflets towards the left ventricular apex. However, in the second case, it is tall because the left atrial pressure is high, because the left ventricular relaxation is so impaired that blood has not moved from the left atrium into the left ventricle prior to the opening of the mitral valve. So because of that, when the valve opens, there is a pressure gradient, and the increased pressure gradient is what is pushing blood into the left ventricle rather than the normal process of it being pulled into the left ventricle by a suction pressure. So what do we do? Okay, so one option is, we know that there is something called tissue Doppler. We can track the movement of the myocardial tissue itself. Now in both of these situations, the movement of the myocardial tissue will be different. Okay, in the first situation where it is a athlete, the myocardium will relax vigorously and there will be definite movement of the myocardial tissue away from the probe. Whereas in a unhealthy person who's got uncontrolled diabetes, or is obese, in such a person, because of molecular level changes and cellular level changes induced by this kind of this process, there will be an impairment of the relaxation. So as a result, the myocardial tissue will not actually move in that as vigorously. Okay, so what do? We assess the speed with which this moving away of the tissue away from the probe is occurring. Okay, so what would we use? We would definitely use tissue Doppler. So tissue Doppler basically allows us to directly see what is the velocity with which a particular section of the myocardial tissue is moving towards or away from our probe. Okay, so this is now apical 4-chamber view, and in this apical 4-chamber view, we have a right ventricle, we have a left ventricle, we have a right atrium, and we have a left atrium. So once we get our orientation, what we've done is we've kept the line of interest over the lateral mitral leaflets insertion. Okay, so we've kept it over there on the myocardial side, okay, at the base of the ventricle. Now what do we find? We play it and we find that this is the curve that we find. Okay, so now this curve is something that we need to understand very intuitively. So what we've done is we've checked the tissue velocity towards the probe being positive, away from the probe being negative. Okay, and plotted it against time during one cardiac cycle. Okay, so during the initial parts of systole, what happens is there is isovolumetric contraction. Okay, so what is happening is that the ventricular wall is contracting. Okay, so what happens is that the apex is pulled towards the base and the base is pulled towards the apex. Okay, so this is the base to apex contraction vector. So because of that, the leaflet is actually being pulled towards the probe. Okay, or the base of the leaflet is being pulled towards the probe. So we get a positive deflection or an increase in velocity corresponding to this isovolumetric contraction. Okay, now after that we get the opening of the aortic valves. Because of that, ejection starts. Okay, so blood starts to be ejected from the ventricle, and as blood is ejected from the ventricular size becomes even smaller. Okay, so now once the ventricular size becomes smaller, again the apex and the base will come closer to each other. So during that period, the apex and the base come closer to each other initially very fast, and then there is a return back to the normal. Okay, then what happens is that there is the ejection, the aortic valve closes, and as the aortic valve closes, the ventricular relaxation would begin. But ventricular relaxation initially is isovolumetric relaxation. Okay, so during isovolumetric relaxation, there is initial relaxation of the ventricle, but we've discussed that the ventricle relaxes in a sequence. So relaxation first begins, so depolarization begins from the subendocardial myocardium, goes to the mid myocardial myocardium, and then goes to the subepicardial myocardium or pericardial myocardium. So similarly, the relaxation happens in the reverse order. So it is the subepicardial myocardium that relaxes first, and it is the subendocardial myocardium that relaxes last. Okay, so because of that, the sequence of depolarization and then repolarization, or depolarization and relaxation rather, okay, there is a positive deflection towards the probe in the isovolumetric relaxation as well. Okay, so this is a little counterintuitive, but this is what happens. Okay, now after that, this is the point where we get interested, because we're talking about diastolic movement. Because the ventricle is relaxing, or would be relaxing in a normal person, okay, there would be a negative pressure within the left ventricle, and that would cause your leaflets to open up, or to move towards the probe. Okay, so we have not kept the probe, the line of interest, on the leaflets. We've kept it in the myocardial tissue at the base of the leaflets. Okay, so now what is happening is that the myocardium is relaxing. So because it is relaxing, this part of tissue is actually going to move away from the probe. So because of that, we end up getting a negative deflection during the early rapid filling. Okay, this is very important. It is negative, unlike our E wave. So this wave is what we call the E prime wave. I've actually enlarged the diastolic portion of our pressure volume curve and put it here. So this corresponds to the early rapid filling. Okay, it's color coded in the same way, yellow for early rapid filling. After that, there is diastasis. So during diastasis, essentially very little movement of tissue occurs in either direction. So you get a flat line. And then finally, we have your atrial kick. Okay, now atrial kick means atrium is contracting. So the atrium contracts in this direction. This is how the atrium will contract. Okay, so now the atrial kick will also pull this tissue away from the probe. Okay, so it will pull it away from the probe, producing a negative deflection. So this is then called the A prime wave. So this is the E prime wave, and that is the A prime wave. Now, just as a side note, during systole, we've already discussed this is the S prime wave. Okay, so this is what we were assessing when we were assessing left ventricular systolic function. So now we will be discussing left ventricular diastolic function. So we are interested in the E prime wave in isolation. So what we've done is we've taken a apical four chamber view of the heart. We've put the line of interest on the septal aspect of the mitral annulus. Okay, so this is the septal aspect of the mitral annulus, and we've plotted it against time. So either whether it is a septal or the lateral aspect of the mitral annulus, the velocity of movement differs, but the tracing is of the same morphology. Okay, so we will be using this as a to give away a spoiler, to differentiate between constrictive pericarditis and restrictive cardiomyopathy in the next discussion. But for now, understand that they are essentially very similar to each other. It's just the magnitude that is different. So what you find here is that you get the same thing. So this is isovolumetric contraction, and this is ejection. Okay, this is isovolumetric relaxation, and then we start having early rapid filling. The mitral annulus is now being pulled away from the probe, so you get a negative deflection. Now, why is it being, actually it is being pushed away from the probe, not pulled away from the probe. So why is it getting pushed away? Because the ventricle is relaxing. So this represents ventricular relaxation. Okay, and then we have diastasis, in which essentially everything is flat, and finally we end up getting a atrial kick, because of which we have a negative deflection, because this time the mitral annulus is actually being pulled away from the probe by the left atrial contraction. Okay, so this is left atrial contraction. So this is our curve. Okay, so once we have this curve, what do? We essentially measure the E prime velocity almost as an absolute term. So the E prime absolute values of E prime velocities are checked on the medial and the lateral ventricular aspect, and then accordingly we will say whether diastolic function is normal or not. Now actually the parameter that is the most directly related to left atrial pressures, okay, that is the ratio between what we get from our pulse wave Doppler, that is the E wave, to the E prime wave. Okay, so why is this important? Because as we've seen, as diastolic dysfunction worsens, what you get is you definitely have a reduction in the E prime wave. Okay, and even though there is an initial reduction in the E wave, that is in grade 1 diastolic dysfunction, eventually you will have an increase in the capital E wave, okay, in the pulse wave Doppler. So actually what happens is that the ratio between the two, okay, this ratio is directly proportional to left atrial pressure. and we use this relationship actually to quantify left atrial pressure. We say that it is elevated or not based on this, and it is directly proportional. So if it is elevated, you definitely need to consider that the patient has a left increase in left atrial pressure. So see, the E wave can represent negative. See, it always represents movement of blood from the left atrium into the left ventricle, but that movement could be the result of left ventricular dilatation resulting in negative pressure within the left ventricle causing a pulling towards the left ventricular apex, or it could be due to left atrial pressure increase which is causing blood to be pushed into the left ventricle. So either of the two is possible, and that can only be differentiated using this ratio. So what we do is we use the most direct measure that we have, that is the E prime velocity. That is the actual velocity of the base of the mitral annulus towards or away from the probe. And in this case it is towards the probe. Okay, and this will definitely decrease if there is an impairment of ventricular relaxation. So E prime, if asked what is the best measure, it would be E prime. Okay, what is the best isolated measure, it would be E prime. Best absolute measure is the ratio between E capital E and E prime. Okay, so I hope that much is clear. Now this is a short discussion, so we'll be concluding it with some other measures of diastolic dysfunction. Now other measures of ventricular dysfunction are measured using continuous wave Doppler. So what do we do here? Okay, well, we've taken an apical four chamber view, put the probe at the apex of the heart, and then tilted it up. Now we've kept the line of interest on the left ventricular outlet. Now as you can see, now this is not an apical four chamber view per se. This is actually a slight variation of the apical four chamber view, which is called the apical five chamber view. Okay, so what we've done is we've tilted the probe a little bit further. That is, the base, the wire of the probe is tilted a little bit more downwards and towards the left side of the patient. And what we find is that the left ventricular outflow tract is now coming into view. Now if you keep doing this a little bit more and a little bit more, eventually you will start seeing a transverse hypoechoic structure here, that is your coronary sinus. So that then becomes a coronary sinus view, and novice, people who are just learning how to do echocardiography often get confused by that view. So don't go that far. Once you start seeing the coronary sinus, that is now no longer the apical five chamber view. Now either way, when you get the apical five chamber view, and I would strongly suggest you learn it from a proper cardiologist or an experienced echocardiographer. Okay, but the interpretation is regardless the same. So what you do is you put a continuous wave Doppler probe, in between the left ventricular outflow tract and the inflow of the left atrium. Okay, so let's see what happens. So once we do this, we end up getting this kind of curve. Okay, so what are we seeing here? So what we are seeing here is that there is a big negative velocity. Okay, and this big negative velocity has to be something that is moving away from the probe. So if it is moving away from the probe, the only thing that will move away from the probe is blood within the left ventricular outlet. Okay, because it always moves from the left ventricle to the aorta in normal people. Okay, so what we're getting is a large negative deflection, and this is likely systole. Okay, now after systole we will have a normalization of the flow. So this is the flow of blood. Okay, so there is no flow of blood from out of the left ventricle into the aorta or between the left atrium and the left ventricle. So since there is no flow of blood, there is no change in the volume of the ventricle. So this would represent isovolumetric relaxation. Okay, and since the x-axis is time here, what we are measuring on this axis is actually the time. So this is known as isovolumetric relaxation time. Okay, then what we find is that there is a diastolic opening of the mitral valve, and that diastolic opening of the mitral valve initially has a early rapid filling wave that is called the E wave. Okay, now as you can see, the second half of the E wave, that is the deceleration time. Okay, so the LV diastolic deceleration time is from the peak of the E wave till the termination of the E wave. So this is what we call the LV diastolic deceleration time. Okay, so these are also indirect measures of the left ventricular relaxation. Okay, but obviously these are indirect measures. Okay, so now why are they measured? Why are they indirect measures? So at this point you have a mitral valve opening. Now the more the left atrial pressure, the faster it will equalize with the left ventricular pressure during diastole. Okay, so if there is an increase in left atrial pressure, the isovolumetric relaxation time would decrease. That is the first thing. Okay, again, once the left ventricular pressure has increased significantly, the left atrial pressure and the left ventricular pressure during early rapid filling would also become equal faster. Okay, so as a result, you would end up getting a faster deceleration or a reduction in the velocity of the E wave during early rapid filling. Okay, so both of these parameters decrease in diastolic dysfunction. Isovolumetric relaxation time is actually quite directly related to the left atrial pressure, whereas LV diastolic deceleration time is related to the left ventricular, the amount of negative pressure that can be developed within the left ventricle. So it is directly related to the negative pressure within the left ventricle. So even without measuring E prime, we could technically talk about, give you can get an idea about what is causing the diastolic dysfunction. Is it just a reduction in the negative pressure that is being developed within the left ventricle, or is it both? Is it both an increase in the left atrial pressure and a reduction in the left ventricular pressure? Okay, but all of this is subverted by the fact that we can do tissue Doppler and directly measure movement of the myocardium, and therefore we have the E prime wave. And like I discussed, the E by E prime ratio is actually the best marker of left atrial pressure. Okay, it is directly proportional in most situations except for constrictive pericarditis, as we will see in a subsequent video. Okay, so this is what we find. Okay, in the first case, we've got an apical 5-chamber view, and now we have a continuous wave tracing. Okay, so in this continuous wave tracing, what are we finding? We have a large negative systolic movement of the blood out of the left ventricle. We have a slightly short A wave, and then we have a E wave. Okay, and then again the entire thing starts. This is what we can measure, and this time difference between this area, this will become what we call the volumetric relaxation time. Okay, so you can correlate it with the diagram. So this is your isovolumetric relaxation time. Okay, now in the next video, what I'm going to do is I'm going to take a detour back through physical examination. Okay, now you would have a lateral E prime velocity that is less than 10 meters per second, has an abnormal relaxation, and a medial prime velocity less than 7 meters per second is abnormal. Okay, but again, the absolute values are not as important as the ratio between E and E prime. Okay, so that is something that we need to keep in mind, and next time I'll be highlighting how a physical examination becomes relevant in a patient with diastolic dysfunction, because often as an internist or a person who doesn't specialize in an organ, a specialist who doesn't specialize in an organ, such as a clinical immunologist or rheumatologist or an infectious disease specialist or a hematologist, an endocrinologist, what you will find is that you will get a report showing diastolic dysfunction, claiming to show diastolic dysfunction. Okay, now from your point of view, what is causing the diastolic dysfunction is very important, because there may be a few differentials that could cause diastolic dysfunction, and one of them, that is a restrictive ventricular pathology, would result in a restrictive myocardial ventricular pathology would be a clear explanation for your patient's shortness of breath. Okay, however, something like chronic constrictive pericarditis or constrictive pericarditis would not be a reasonable explanation for your patient's shortness of breath, because such a patient would rather have more features of right ventricular failure in the form of ascites, bilateral swelling of feet, that is pedal edema, tricuspid regurgitation, okay, enlargement of the liver, pulsatile liver, such things. So how do you differentiate? Okay, so how do we use the physical examination to differentiate between the two? That will be the topic of next discussion in the series. Okay, so thank you, and I'll see you in the next session.